Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is part 2 for Pediatric Life Support, where we look at advanced life support options. The learning objectives for this session are to review artificial airways, circulatory adjuncts, defibrillation, look at differential diagnosis, emergency medications, and conclude with some case scenarios. Oropharyngeal airways. They are for unresponsive, unconscious victims only. They maintain the airway, they do not protect it. If we insert an oropharyngeal airway, we measure from the corner of the mouth to the angle of the jaw. We insert the tip along the roof of the mouth, hard palate first, soft palate second, turn 180 degrees, and you insert it until the flange rests on the lips. The flange rests on the lips. When we employ a nasopharyngeal airway, this is for responsive or unresponsive, conscious or unconscious victims, but note, you don't maintain the airway, you don't protect the airway, it's a tool that's used for suctioning and clearing the airway. The insertion procedure is to measure from the tip of the nose to the tragus of the ear. You insert the tip along the upper nasal wall after lubricating generously. Rotate it gently until the flange rests on the nares. With circulatory adjuncts, these can include intravenous, intraosseous access, advanced airways, transcutaneous pacing and cardioversion, defibrillation and medications. Transcutaneous pacing and cardioversion we won't be covering in this lecture, but they are adjuncts. Intraosseous access, emergency medications, resuscitation fluids. Now with advanced airways, we've got laryngeal masks, tracheal tubes, suction devices, and end-tidal CO2 capnography. Laryngeal masks are pretty simple to insert after you've had instruction, but they're not being reviewed in this lecture. Tracheal tubes require expert consultation and additional skill training, also not reviewed in this lecture. Suction catheters can be oropharyngeal for the large airways. Tracheal tubes require smaller, thinner suction catheters. End-tidal calorimetric carbon dioxide detectors, they can assess the accuracy of tube placement after tracheal tube insertion. A handy tool. But remember, tracheal tubes are not a priority unless breathing cannot be provided by bag mask ventilation. When we look at defibrillators, these are devices that deliver an electrical shock to the heart. An AED, an automated external defibrillator, can be employed by BLS providers. The manual defibrillator really should be employed by advanced cardiac life support providers who have been shown and are skilled in using the device. Defibrillators essentially are devices that attempt to restore a normal heart rhythm by delivering an electrical shock to the heart. They correct arrhythmias such as supraventricular tachycardia, SVT, ventricular tachycardia, VT, or ventricular fibrillation, VF. They can be monophasic, which means the pediatric energy is delivered in one direction through the heart, and the first dose is typically 2 joules per kg, with subsequent doses being 4 joules per kg. Then you've got biphasic defibrillators, and this is where energy is delivered to the paediatric in 2 directions through the heart, in opposite directions. The first dose remains the same, 2 joules per kg, and subsequent doses will be 4 joules per kg. They also correct arrhythmias such as SVT, VT, or VF. Defibrillation techniques can include hands-on with paddles or hands-off with pads. Defibrillation, however, is less commonly required in paediatrics, but if required, it's used to convert ventricular tachycardia or ventricular fibrillation. When we talk about SVT, this is really cardioversion. Cardioversion is different to defibrillation. It's an elective procedure, which we're not going to be covering really in this workshop. Essential rhythms to recognise for cardiopulmonary resuscitation and defibrillation are ventricular tachycardia and ventricular fibrillation, because we need to defibrillate these as quickly as possible before they deteriorate into a non-shockable rhythm. Bradycardia and asystole are not shockable. No defibrillation is required here. The defibrillation procedure is as follows, and this is just an overview. Apply gel or gel pads. Verify that it's a shockable rhythm on the cardiac monitor, VT, VF. Select the energy setting, monophasic or biphasic. Place the paddles on the chest, apply firm pressure, and then press the charge button. Before discharging, recheck if it's still a shockable rhythm on the cardiac monitor, VT or VF. Then alert everybody. Tell everybody clear. Make sure they're clear. Make sure yourself is clear. Then press both the discharge buttons simultaneously after ensuring that everybody is clear. Then resume CPR immediately. Don't do a rhythm check. Don't do a pulse check. Give 5 cycles of CPR, which is approximately 2 minutes. Then check the pulse. Then check the cardiac rhythm. When we come to differential diagnosis, this is a great mnemonic to remember. And this is what you consider during the cardiopulmonary resuscitation, when defibrillation is refractory, which means it's not working. You're shocking the patient and they are still going back into VT or VF. It's refractory. So you have the 7 H's. Consider the patient could be hypovolemic, hypoxemic, hypo or hyperkalemic, hypoglycemic, hypothermic. They could be in a metabolic or respiratory acidosis, hydrogen ion acidosis. Consider that and recommend it, possibly, to the team leader. Then you've got the 7 T's. Following trauma, which could be surgery, cardiac tamponade, pneumothorax, thrombosis, coronary artery thrombosis such as STEMI, pulmonary embolism, toxins such as tablets, which could be cardiotoxic, or cardiac transplant. Resuscitation medications for pediatrics, probably the most important one is oxygen. And this is important, especially with effective CPR. It improves tissue oxygenation. It's indicated for respiratory insufficiency, distress, failure, saturations of less than 94%, chest pain, cardiopulmonary arrest. And the dose is always at its maximum, 15 litres per minute, which should provide 100% oxygen. You've got epinephrine, also known as adrenaline. The action is as a sympathomimetic. It stimulates alpha, beta 1, beta 2 receptors. and it's indicated for symptomatic bradycardia, pulseless VT or VF, asystole and PEA, pulseless electrical activity. The dose in pediatrics is 0.01 milligrams per kg of a 0.1 ml per kg solution, 1 in 10,000. And this is repeated every 3 to 5 minutes with no maximum cumulative dose. Amiodarone, another effective medication. It's a broad spectrum antidysrhythmic. It is class 1, 2, 3, 4 as an antiarrhythmic, and it's indicated for defibrillation refractory VT and VF. The pediatric dose, for the first dose, is 5 milligrams per kg as a bolus, and the second dose is repeated, 5 milligrams per kg. The maximum dose, however, is not to exceed 15 milligrams per kg in 24 hours. Then you've got calcium chloride. Calcium chloride is a positive inotrope. It increases contractility of the myocardium. It's an essential mineral and electrolyte, and it's indicated for hypocalcemia, hyperkalemia, calcium channel blocker overdose, magnesium toxicity, and beta blocker overdose. And the pediatric dose is 20 milligrams per kg or 0.2 mils per kg. There's no maximum dose. Dextrose 50% also can be diluted to 25%, and the action is to increase blood glucose in hypoglycemic patients. The pediatric dose is 0.5 to 1 gram per kg, and as you can see, 0.51 gram per kg at 50%, or 0.5 gram per kg if you want to give 25%. Magnesium sulfate is an antiarrhythmic. It has a weak class 1, 3, 4, and 5 effect. It's an essential electrolyte, and in pediatrics, it's especially important for polymorphic ventricular tachycardia, also known as Torsades de Pointes. The pediatric dose is 25 to 50 milligrams per kg with a maximum dose of 2 grams. Sodium bicarbonate, 4.2%, although not often recommended, is sometimes employed, and it increases plasma bicarbonate and elevates the blood pH. The indications are for hyperkalemia, a prolonged cardiopulmonary arrest, which results in a profound metabolic acidosis. The pediatric dose is 1 milliequivalent per kg of a 4.2% solution, and subsequent doses can be given 10 minutely of 0.5 milliequivalents. Atropine as a resuscitation medication. It's a parasympathetic muscarinic blotter. It increases heart rate and it's a bronchodilator. And it's indicated for vagally induced bradycardias. And in pediatric doses, it's 0.02 milligrams per kg every 3 to 5 minutes with a maximum dose of 1 milligram, however, not less than 0.1 milligrams. As far as the American Heart Association are concerned, it's no longer recommended for asystole or pulseless electrical activity, as it's been shown to have no benefit and probably be more detrimental than beneficial. Atropine sulfate. Now let's review. Name the resuscitation adjunct recommended for unresponsive victims to maintain the airway. These are oropharyngeal airways. They maintain the airway, but they don't protect it. Name the resuscitation adjunct recommended for responsive victims to allow suctioning of the airway. These are nasopharyngeal airways. They don't maintain the airway, they don't protect the airway, but they do allow suctioning to clear the airway. Name the defibrillation device which can be employed by BLS providers if required. This is an AED, an automated external defibrillator. State the cardiac dysrhythmias which require defibrillation. The dysrhythmias are ventricular tachycardia and ventricular fibrillation. They need to be defibrillated ASAP before they deteriorate into non-shock rhythms. State the resuscitation medication which is in all probability considered the most important with effective CPR. Oxygen. Oxygen is probably the most important resuscitation medication, especially in pediatrics, in conjunction with effective CPR. Okay, let's conclude with this case study. Newborn, 4.5 kilogram male, diagnosed with congenital heart disease. He's unresponsive, pulseless, and the cardiac monitor shows this rhythm. What's the rhythm, and how would you treat it? The Dr Manny Learn shocks on the ECG are very beneficial in relation to these sorts of rhythms. So have a look at them if you choose to. The rhythm is polymorphic ventricular tachycardia, also known as Torsades de Pont. You would start with BLS after having activated the emergency medical response. Defibrillate with 2 joules per kg, monomorphic. VT requires fibrillation. Or you can give epinephrine or magnesium sulfate. Now please note the magnesium sulfate dose is incorrect. That should read 12.5 milligrams, not 112.5 milligrams. Then we have a 4-year-old 15 kilogram male following post-complex cardiac surgery. He's got heart disease and he returns to the ICU. His current situation is that he suddenly becomes hypotensive and the cardiac monitor shows the following rhythm. What's the cardiac rhythm and how would you treat it? The cardiac rhythm, or non-rhythm, is asystole. You provide BLS, activating the emergency medical response, and giving epinephrine 0.515 milligrams of a 1 in 10,000 solution every 3 to 5 minutes, because all medications are worked out according to weight. Okay, that's the end of the life support Learn shocks. If there are any other Learn shocks in respect to resuscitation that you would like, please advise. Please recommend the Learn shocks to your colleagues if you found them of any benefit. Subscribe if you choose to. Ask questions. And please check out the other Dr Manny Learn shocks on YouTube. Cheers for now.